Okay, thanks very much. So moving on, let's see, is Dr. Barron here? Oh, didn't see her back there. So next we have Ellen Jo Barron, who's Emerita Professor of Pathology at Stanford and is currently Executive Director of Medical Affairs at Cepheid. Dr. Barron has extensive professional career involved in clinical microbiology, development of diagnostics, and their utilization.
I'm not sure I know how to advance the slides. There's no clicker. This a clicker? Green button. Thank you. I would like to say that I have equal experience in developing world with my NGO, Diagnostic Microbiology Development Program. Shown here, I'm teaching in some of the places that I teach. I work as Executive Director of Medical Affairs in a diagnostic commercial company and Stanford University, and none of those people have influence on what I'm going to say today. It's my own. So I was asked to answer a number of specific questions. First of all, what's the value of investing in diagnostics? And I would like to give a couple examples. One is the Ebola outbreak. In this outbreak, patients were handled by people who were completely gowned in double protective garb, and anyone who had a fever in the Ebola area, in which malaria and salmonella, typhi, and other diseases are rampant, was placed in an Ebola quarantine treatment unit until they were proven to be negative, and those people were held for up to 8 days. So if you did not have Ebola and were placed into the Ebola quarantine area, you certainly had it by the time you left, because you were waiting for results from a distant reference laboratory for Ebola test. So a rapid test was developed. You can see here that it performed as well as other tests that were performed in the reference laboratory. Médecins Sans Frontières published that their people were very happy. These black bars indicate satisfaction with all kinds of positive statements with regards to use of it. So how did that help? What difference did that sort of diagnostic make? Well, you could make a diagnosis at the time and point of management and make a decision within an hour. So patients who were not infected were not placed at risk with the other infected patients. The healthcare workers could perform sample taking in a more expeditious and safe ways for themselves, and so they were not placed at so much risk of infection. And as you know, in some sites, 50% of healthcare workers also succumbed to Ebola. And the test allowed further studies such as monitoring of semen, breast milk, further on, etc. Another test that many of you are familiar with is the MTB-RIF. It happens to be from the company I work for, but Dr. Madhu Pai has written extensively, and what he said is that the rollout of this test, particularly for drug-resistant TB, sorry, I have to go back, I don't know how, okay, has increased rifampin-resistant TB case detection by over 5-fold. There just was a paper last year published on lessons learned, and what they said, this is where the test is being used now. It's in 122 of 145 high-burden developing countries for which Global Fund provides some support, and we have to certainly thank the Bill and Melinda Gates Foundation for underwriting the cost of this test. Many of them have been performed now, and the detection of MDR-TB has increased 3 to 8-fold, and the rollout has galvanized other TB researchers and stakeholders to get into the TB field. However, in most of the studies, no difference in mortality, and in some studies, cost of the rollout was higher or only cost neutral. So why? I think the same system inadequacies that Dr. Linder noted yesterday, which is the diagnostic test is not the only answer. You need a system that can utilize it as intended and that people don't do empiric therapy. We were just hearing about microbiome, I think, and Dr. Klugman just mentioned 30% of patients in labor receive antibiotics. We aren't just talking about developing antibiotic resistance in this case. we are talking about obesity as a function of disturbing the microbiome of babies who come through the birth canal in a penicillin-laden environment, and their microbiome is disturbed. And so I believe what type of diagnostic test should be priorities? I have 4 themes. The first is those for which there is an immediate patient benefit from that patient management decision, or that it will impact public health. So group B strep, I think, is going to impact both. And here's a study from France just basically showing that it was cost neutral to have an interpartum diagnostic, and that the probability of GBS disease in the neonates was cut in half. Now, in this case, more women received intrapartum prophylaxis than in the antenatal test, but very few women received antenatal tests at all in France. They're using all intrapartum testing. So I think cutting down the use of intrapartum prophylactic antibiotics by knowing which patient is colonized with group B strep at the time of delivery will help with this infant obesity epidemic, as well as cutting down on use of antibiotics and developing resistance. Here's another real-world situation where there's both a developed patient benefit, but also a public health benefit, and that is sexually transmitted infections. So this was a paper published by Larissa May in 2016, looking at using a rapid polymerase chain reaction test in the emergency department. And what you found was basically empiric treatment for chlamydia, gonorrhea was dropped down 35%, and subsequent hospitalization went down, and notified results went up by 56%, symptoms resolved, et cetera. So having a rapid test made a massive difference. And if you don't have a sexually transmitted disease, you're given your antibiotic immediately as soon as you leave the emergency department. You are not passing it on to other people. So having rapid diagnostic tests for STIs, for example, in London at the Dean Street Express, has actually reduced the community burden of chlamydia and gonorrhea in those areas of London where these rapid tests are being deployed. So what type of diagnostics should be prioritized besides the one I just mentioned, which has an immediate patient and public health benefit? I think clinical trials. If we're talking about a vaccine trial, we have Ebola tests that are now being used in an Ebola vaccine trial to make sure the patients enrolled don't have Ebola. So any tests that can rapidly identify patients eligible for clinical trials of new antimicrobial agents should be developed. Rapid tests that would rule out bacterial infection at patient presentation. So we've heard this from other speakers. A number of companies are working on such a thing. If you knew it was a virus at the moment the patient showed up, you wouldn't give them an antibiotic. So these kinds of tests, maybe there'll be human immune response tests or biomarker tests and not even pathogen tests, but those kinds of tests should be developed. And then surveillance. We haven't talked much about surveillance, but rapid tests to detect, I keep hitting the wrong button, sorry. Rapid tests to detect resistance factors directly in patients would either inform what kind of prophylaxis you use for surgery. If you have, for example, MRSA, or Staph aureus, you would choose a different prophylactic for an invasive surgical procedure. If you knew a patient had carried carbapenem-resistant Enterobacteriaceae, you may place that patient in isolation and prevent transmission in your hospital setting. Patients with carbapenem-resistant or methicillin-resistant Staph aureus, if you could have a rapid test that you dipped into the sputum and knew that they had that, you could tailor your antibiotic to those sorts of patients. Here's an example of having a rapid PCR test for KPC-producing Klebsiella, and what you see is that when they were using the KPC PCR, time to isolation, contact isolation was 1.5 days. When they were using a culture, it was 5 days. There was a lot of transmission occurring during those 5 days, and the study epi curve shows you that there were infected and colonized patients, and at the moment that they started using the rapid PCR test, it just dropped down almost to nothing and then went to nothing, and there were no more cases. It completely stopped the epidemic. Now, I don't want to forget connectivity. We haven't talked too much about that, but knowing what resistance factors or what organisms are out there at the time of the testing in real time and brought up to so that public health people and others can see those data are going to be very important. So this is a system that's been employed by the Republic of South Africa for many years. They're tying together all kinds of diagnostic test results, putting them together in the cloud, and then the public health people can see on a geoposition map what sorts of organisms, what sorts of diseases, what sorts of resistance factors are present throughout the country. And here's just an example of using it for tuberculosis. And what you see here is these are where tuberculosis is highest concentration on this heat map. And this is where rifampin resistance is highest concentration. So you can put your reagents where they need to go. You can add interventions, public health interventions, where they need to go. You might be asking yourself, why is that little red place there? This is Swaziland, and we have resistant organisms being spread from Swaziland over into parts of South Africa. So what are the challenges and the needs to accelerate the development of these diagnostics? Companies need to know that they are going to make money. Lack of predictable profit. Ebola would never have been created, that test, if the Bill and Melinda Gates Foundation had not said to Cepheid, here's $2 million to make an Ebola test. And Cepheid had some very prescient scientists who'd already been thinking, boy, we ought to make an Ebola test. That was before we got sold to Danaher. And now we have been sold to a giant holding company who has a bottom line interest. And we would never be allowed now to be thinking, wow, we ought to be making an Ebola test in advance of even needing an Ebola test, because there is no profit motive there. Clinical trials, cost, requirements, regulatory issues, review time, difficult demands. There are 37 countries that require their own clinical trials before a diagnostic can be introduced there. Huge cost implications. New companies don't have the resource to do that. Final cost of product and market acceptability. You can make a prototype super cheap, but when you need to scale up and make millions of these things and have them all give you good quality results, that is extremely difficult. You need outcome studies. Thankfully, FIND supports outcome studies for TB drugs and some of the other orphan drugs, HIV viral load at point of care, et cetera. And then what happens when the bug changes? Staph aureus, we heard yesterday about the new MEC-C. All the tests that were in the use in the world were MEC-A tests. All of a sudden you have a MEC-C test. If you want to change your test, update it, and make it available, you have to do a new clinical trial and pay millions of dollars and go back through all those 37 regulatory agencies. It is not easy to do that. So how might Drive DX idea help? This was something that was asked to me. I never heard about it. I looked it up. It's some kind of incentive program. It would incentivize developers if you had a guaranteed purchase agreement. If you make it and no one buys it, it is not going to help your bottom line. And secondly, with regard to regulatory requirements, let's make FDA more like CE marked, where a company self-registers a test. Let the market decide if it's good or bad. I know it shouldn't be horrible, but they should have enough data to at least get a drug out there and take a look at it. So what immediate steps can be taken for the greatest short-term impact? Publicize specific target product profiles that you want companies to make, and make them very specific so that companies don't make a product that won't be accepted in the marketplace. Create a rapid, inexpensive regulatory path, which may be abbreviated clinical trials up front and then lots of post-market review and surveillance in order to pull it if it isn't performing as expected. And last of all, companies have to be given sufficient sales guarantee to offset development costs. So all that push money that's being given to companies, here, we'll give you $500,000 to make your test. Then they make the test, and then nobody buys it. They've just lost $500,000. There's no incentive if you don't have a guaranteed market. And so pre-purchase agreements, I think, would be very helpful. Thank you. Look, I'm the first person that didn't get the red blinking light.